Start, yeah.
We will formally start the 19th webinar of Pudukkottai ISA in the name of Pudukkottai Budan. Welcome you all. Good evening to all of you. I invite and request our Secretary Dr. M. Periyaswamy to put forward the welcome address.
Thank you, sir. Good evening, respected academic chairman Dr. A. Meena Sundar sir, President Dr. Suresh Kumar sir, President Dr. David, member of ISA Pudukkottai, and delegates, those who are attending this 19th webinar from Pudukkottai Budan. I welcome you all on behalf of ISA Pudukkottai. Once again, I welcome all the people, those who are attending this 19th CME of ISA Pudukkottai online webinar, Pudukkottai Budan. So already we discussed about 55 topics from various headings. Last week, we discussed about nerve block strategies for knee surgeries, approach sciatic nerve block, and nerve block for lower limb surgeries. And we are our online CME webinar is accredited by Tamil Nadu Medical Council. So if you want to apply for credit hours, these are details given here. You can note it down and apply to the ISA Pudukkottai@yahoo.com with 100 rupees you have to pay for us in the above said account number. This week we are having 3 eminent speakers and well-known person Dr. Gurumurthy, a director, Dr. Skuru, International Pain and Palliative Care Trichy as a chairperson. On behalf of ISA Pudukkottai, I welcome you, sir. Next, as speakers, we are having 3 persons from Multimodal Medical College, Chennai, Dr. G.K. Kumar, Professor and Medical College Hospital, Multimodal Government Estate, Chennai, to talk about management option for chronic pain. We welcome you, sir. Next, Dr. Aishwarya, Assistant Professor of Anesthesia, Government Medical College Hospital, Multimodal Government Estate, Chennai. Madam is going to talk about Celiac Plexus block. Welcome you, madam. And next, a resident Dr. R. Niveta, Department of Anesthesia, Government Medical College Hospital, Multimodal Government Estate, Chennai. Madam is going to talk about gate control theory. On behalf of ISA Pudukkottai, once again, I welcome you all for this 19th online webinar CME program. Welcome you all, sir.
Thank you, sir.
Thank you, sir. This is the, I have to pay 100 rupees net to the account number of ISA Pudukkottai. And all the details has to send ISA Pudukkottai@yahoo.com. Very important. Today we are having topics related to pain management and pain. So small poem about that. Pain, the protective mechanism to the cause to protect the body mass. Pain, the cause for anger. Pain, anger, the cause strain. Sometimes pain, the cause for gain. Pain, the beginning of our life, which comes for birth. Pain, the pleasurable life which comes before our birth. Pain, the subjective sensation. Everyone pray for strength over healing. Let's look up for divine healing. Let us. With this, I thank you all for this opportunity. Thank you all. Thank you, sir.
Thank you, Dr. Periyaswamy.
Thank you, sir.
Thank you. Respected our academic chairman, Professor Dr. A.L. Meenakshi Sundaram, sir. Today's eminent speakers, Professor and Head of Anesthesia, Multimodal Medical College, Dr. G.K. Kumar sir, Assistant Professor of same college, Dr. Aishwarya Madam, and resident of the same college, Dr. Nivetha. And today's chairperson, Dr. Gurumurthy sir, assembled delegates, seniors, officials, and the office bearers of Tamil Nadu and other parts of India. As President of ISA Pudukkottai branch, I once again welcome you all for this webinar. Today's webinar is very important. I just want to quote an old poem by John Milton. Pain is the perfect misery, the worst of all evils, and if excessive, it overturns all patients. So as anesthesiologists, we are managing acute pain always. But what about the chronic pain? When all our pharmacopoeia fails, still patient suffers from pain. What are all the things our secretary listed will come up, and the patient may go himself for suicide. So at this juncture, chronic pain management is the part of the life today, and our anesthesiologists, many of our anesthesiologists from all parts of the country came forward, and they are dedicatedly managing chronic pain. And as a result, our ALM sir has put forward this nice topic. And I request all the delegates and other postgraduates to make use of this session and have a nice day. I hand over all the proceedings to the Dr. ALM sir to conduct this session. Thank you.
Thank you, President ISA Pudukkottai, respected dignitaries of ISA and faculty for Pudukkottai Budan today. I wish you all a very good evening. Today, we are concentrating on a new topic, that is a chronic pain relief. Because so far, our topics were dealing with acute problems. And now, the anesthesiologists are donning the role of a pain physician. And even the examination questions are many from for chronic pain relief. So when we have decided this topic as a government official, the first person came to my mind is Dr. G.K. Kumar, because I am seeing Kumar as one of the interesting personalities in the government setup. Majority of the people working in government setup, they will be cursing the thing, this is not available, that is not available, this is not available. But even from the assistant professor level, when pain medicine was not discussed in government hospitals, he was the one who pioneered that. See, people used to treat him as just a DVA aberration in the government setup, but he was concentrating all along these years, and he has established himself as a pain man. In government side, if you ask anyone to quote a pain physician, definitely Dr. G.K. Kumar will be the first one in that. He is presently heading the anesthesia department in government Omandurar Medical College. So he is interested in chronic pain relief for so many years, and now he is concentrating on cancer pain relief and head and neck pain relief. So I requested him to nominate two other faculty, and he has correctly picked up Dr. Aishwarya and Dr. Nivetha. Dr. Aishwarya obtained her anesthesiology degree from Trichy Medical College, AFBV Medical College, and she is the gold medalist in that year. So that is a good point that she is a golden girl in the anesthesia department now. And she has done a palliative care certificate course in Kerala. You know, Kerala is well known for that because so many pain physicians are there already in Kerala. So she has done that, and now she is doing her fellowship in interventional pain management. So she will definitely come up. So necessarily she is following Dr. Kumar, and she is there in the same department. And as a policy, we concentrate on residents. And now this resident is highly enthusiastic. And just by seeing her photograph, I had a call from Professor Kanchanamala stating that she is her student. Even she will be like that, very much interesting, enthusiastic. Same way that PG is also there. So definitely, I am sure that she will come up. And as usual, we will fix the topmost person as the chairperson for all our proceedings. So necessarily, as we are in Tanjavur and Pudukkottai, the Trichy area, the popular person is Dr. Gurumurthy. So he is a director. He is running a hospital by name Dr. Guru's Pain Management Clinic, and really he is a guru now. He is going to teach all the youngsters. So a name itself says that he is a guru. So he has done his MBBS in Stanley Medical College. In that way, I am very happy where I worked as a team. He was from Stanley. He did his MD anesthesiology from Lucknow, Sahuji Shivaji University in Lucknow, and he has finished his fellowship in interventional pain management and palliative care also. And if you want to exactly start a pain clinic, you can directly talk to him, because he has written a book on how to design a pain clinic. So that is the first thing for any beginner. So he has done that, and he has created 2 videos demonstrating all procedures which will be used in chronic pain relief. So even the painful area he makes painless, and he is one of the pioneer in that. And for even for non-medical people, he is creating awareness in chronic pain relief through All India Radio. He is constantly participating in that. So in that way, he is the right person to chair this session. And now this chronic pain relief will be definitely a painless program for us. So as our target is always 50, we are nearing 50. Now I hand over the proceedings to Dr. Gurumurthy. Please, sir.
Sir, thank you, sir. Thank you for your warm words. So I think you may remember when I went to Tanjavur to meet you, you told about your what you did whenever there is nothing. You did blind celiac plexus, you started doing it. Now I told, okay, sir, at least we are doing something with more sophistication under image guidance. So you may be the best person to start, you may be the first person to start this pain procedure, sir, but we are leading the way. And as you told, you had taught us, now we are started teaching others. So we can directly go to the talk, sir. We can ask Dr. GK, sir. So I think you can start your presentation, sir. So we are trying to make things so simple. So if there is any doubts, please post your queries in the chat box. So we can discuss at the end. As a chairperson, I always like to think time more dedicated for discussion, because that is more interesting than looking at the topics. So please post your doubts, whatever, even it's looking something awkward, don't worry about these things. So start posting, we'll get back to you. So GK sir, please start your presentation, sir.
Sir, first
yes, sir, please, sir.
Chairperson, sir, first Dr. Niveda, Dr. Aishwarya and Dr. Kumar,
okay.
They like that.
Okay, sir, let the team starts as per their schedule.
A very good evening to everyone present here, sir. Today we are here to discuss about the gate control theory of pain. This is a very important theory which forms the basis of various treatment modalities which are available at present and widely used for treatment of chronic pain management. Hence, it is very essential for us to know the basis behind all the treatment modalities which is being widely used. Going into the discussion, the gate control theory of pain was first explained by Melzack and Wall in the year 1965. This talks about the modulation of the pain. Then this modulation of pain determines if the nociceptive signals can be transmitted or attenuated at the level of spinal cord itself, especially at the substantia gelatinosa of the spinal cord. both Melzack and Wall were psychologists who were conducting a research about the influence of the mental states of the patient in the perception of pain. This led to the discovery of this theory of gait control, and they observed that there were influences of the mood of the patient in their ability to perceive pain. The patients who were depressed were found to have an increased perception of pain, and the patients who were found to be in a very happy mood had decreased perception of pain. And they went into that and found that there was something like a gait which allowed the perception of pain and attenuation of pain in the spinal cord. They combined the concepts of both the specificity theory and the peripheral pattern theory of the pain, which were previously described, to form this gait control theory of pain. Once they published a paper about the gait control theory of pain, it was widely recognized and made other researchers to conduct many researches in this area. Because of that, there were development of many new therapeutic approach and therapeutic techniques which could be based on this gait control theory. And it, as a blessing, now we have been using those techniques for the main management of chronic pain in patients who are suffering from pain in their day-to-day life, and making their life a little peaceful one for them. Few interesting facts about the authors includes that Melzack was a Canadian psychologist and professor at McGill University. His other notable accomplishment is that he gave the McGill Pain Questionnaire, which is very much used in the neuropathic pain. And he was the founding member of the International Association for the Study of Pain. Wall collaborated with Bill Sweet to produce the transcutaneous electrical nerve stimulation, which is used for therapeutic management of chronic pain. Once this TENS was developed and published, the gait control theory was even more recognized, and it was much more accepted than it was previously. Wall was the first editor of the medical journal of IASP pain. The key points which are going to be described in my presentation today are functional anatomy, the physiology which is involved in the pain transmission, the functioning of the gait, and the clinical application of the gait control mechanism. To know about the gait control mechanism, it is very essential for us to know the pain pathway. As you could see in this image, there is a painful stimuli of heat from the fingers, which is carried out by the peripheral nerve fibers to the spinal cord and then to the brain for further perception of pain. Let's see the pain pathway in detail. When there is a painful stimulus, the painful stimuli is carried by two types of fibers, A delta fibers and C fibers. A delta fibers are myelinated fibers and they are responsible for carrying sharp pain, and C delta fibers are unmyelinated fibers which carry dull aching pain. These impulses are carried via the first order neuron through the dorsal root ganglia, and they synapse at the dorsal horn of spinal cord. A delta fibers synapse at the lamina 1 and 5, and C fibers synapse at the lamina 2 and 3. From there, these fibers cross to the contralateral side and ascend as lateral spinothalamic tract and constituting the second order neuron. The second order neuron relays in the thalamus, the ventroposterior and medial nuclei. From there, the third order neurons arise and they relay in the somatosensory area 1, which is the postcentral gyrus, and somatosensory area 2, which is the Sylvian fissure in the contralateral cortex. Now we will see the anatomy, that is the fibers which are, include, and we'll see about the modulation of the pain. Basically, there are two places where the pain can be modulated. It is central modulation and peripheral modulation. The peripheral modulation of pain usually occurs at the level of spinal cord and at the level of substantia gelatinosa, which is the gait control theory of pain, which is the topic for today. And the other modulation is through the descending pathway, which arises from the periaqueductal gray region, which also can cause the modulation of pain. we'll go and see the details about the physiological mechanism behind the gate control theory of pain and the nerve fibers involved. The nerve fibers, as we have seen already, involved are A delta, C, and A beta fibers. A delta fibers are stimulated by noxious stimuli and such as pain and temperature. C fibers are also stimulated by noxious stimuli, such as pain and temperature. And A beta fibers are usually large diameter fibers which are activated by non-noxious stimuli. A beta fibers and C fibers are anatomically closer to each other, and that is a very important thing which causes the basis for the gate control theory of pain. The A beta fibers are stimulated by touch, pressure, and any hand movements, etc. This small image shows the pain gate which is present at the level of spinal cord, which is excited by the A delta and C fibers and which is inhibited by the A beta fibers. And we could be this is an animation which shows the pain pathway and the basis of the gate control theory. Now we'll see that there is a painful stimulus which is carried out by A delta and C fibers through the primary neuron, which relays in the dorsal hall of the spinal cord. And in the exactly to be seen, it is modulated in the substantia gelatinosa with the help of dorsal column. But in normal physiology, what happens is that A delta fibers carry the painful stimulus, and because of the painful stimulus, there is release of excitatory neurotransmitters like glutamate and substance P. The glutamate and substance P causes an excitatory potential and causes the action potential at the secondary neuron. Because of the action potential, it is taken to the tertiary neuron and to the brain, and thus pain is perceived by the patient. And this is the pathway which was explained previously, the relay of the primary neuron to secondary neuron. The pain is relayed, and it is the synapse is at the level of thalamus. From the thalamus, the tertiary neuron carries the signals to the contralateral cortex in the post-central gyrus, which is the somatosensory area, which is present in the parietal lobe. And when this pain pathway is modulated at the level of substantia gelatinosa by dorsal column medial lemniscus with the help of an inhibitory interneuron which is present, and the inhibitory interneuron acts as a gate. This gate mechanism acts as shown in the animation further. On deep touch, there is stimulation of Pacinian corpuscles which are present at the dermis of the skin, and the signals from that is relayed via the dorsal column medial lemniscus, which relays in the spinal cord and then further ascends up on the same side, and it crosses over at the level of medulla and relays in the thalamus, and then the tertiary neurons are taken away to the somatosensory cortex. There is an interaction between the dorsal column medial lemniscus and the secondary neuron which carries the pain via the inhibitory interneuron. Now we will see the modulation of the pain which happens at the substantia gelatinosa. There is a stimulation of deep touch through dorsal column medial lemniscus. Hence, the inhibitory interneuron is stimulated, and because of its stimulation, there is a release of neurotransmitters enkephalin from the inhibitory interneuron. This enkephalin binds with the receptors, opioid receptors, which are present in the A delta fibers and causes the calcium channels to close. And hence, there is a decreased release of excitatory neurotransmitters, the substance P and glutamate. Hence, there is a hyperpolarization of the secondary neuron, and hence there is a decreased action potential, and further there is a decrease in the pain perception as the pain signals sent to the brain are reduced. In similar to this, the enkephalins also bind to the postsynaptic opioid receptor which are present in the secondary neuron and causes the opening of potassium channels, which also causes hyperpolarization and decreased action potential and further decrease in the pain signal that is sent to the brain. All this presynaptic and postsynaptic inhibition of the conduction of the pain signals causes the reduced perception of pain ultimately by the patient. This is the mechanism by which the dorsal column medial lemniscus interferes with the pain transmission in the patient. Now we'll see what happens if the pain perception, if the gate is open or the gate is closed. When the gate is open, the non-nociceptive signals allow the nociceptive signals to relay in the brain, and hence the pain is perceived. And when the gate is closed, the signals are not transmitted, it is restricted, and hence there is no perception of pain. In this illustration, we can see that when there is an action potential in the A beta fibers, the inhibitory interneurons are stimulated and they produce an inhibitory signal which inhibits the projecting neuron, which is the second order neuron, and hence there is an interruption of the transmission of the signals. This is what happens when the gate is closed. Even though the C fibers stimulate the neurons, because of the stimulation of A beta fibers, there is no transmission of signal, hence reduced pain perception. When the gate is open, since there is no signals from the A beta fibers, the C fibers are able to transmit the signals from the first order neuron to the second order neuron and further up to the brain. Hence, there is a perception of pain. As a summary, the gate control theory of pain says that the activation of A beta fibers reduces and inhibits the transmission of A delta and C fibers by stimulation of the inhibitory interneurons present in the substantia gelatinosa, which further causes the reduction in the pain perception. The various clinical applications used are discussed further, and the first one to be developed based upon this gate control theory is the transcutaneous electrical nerve stimulation. Here in this image, you can see a transcutaneous electrical nerve stimulation setting, which has a battery operated TENS device with an electrodes, and this device gives pulsed electrical currents through the electrodes, and this electrical currents stimulate the A beta fibers and the which are the large diameter fibers to inhibit the pain transmission, hence modulating the pain which is perceived by the patient. The other modalities of pain treatment which use the gate control theory are interferential current and neuromodulation. The neuromodulation comprises of the peripheral nerve stimulation, peripheral nerve field stimulation, and the recently developed spinal cord stimulation. The patients who were suffering from intractable pain undergo neuromodulation for their treatment after the failure of conservative management. Neurostimulation device is implanted in them for the treatment. Peripheral nerve stimulation and peripheral nerve field stimulations are used for low back pain, neck pain, thoracic pain, abdominal pain, and shoulder pain, where the specific nerve is modulated and there is pain relief. And the epicranial nerve stimulation is done for chronic migraine, chronic cluster headache, hemicrania continua, etc. And now we'll see the spinal cord stimulation, which is the most recently developed neuromodulation technique, which delivers pulsed electrical signals principally to the dorsal column of the spinal cord and hence modulating the pain perception in the patient. Shirley and colleagues were introduced the concept of spinal cord stimulation, and it is indicated in failed back surgery syndrome, traumatic nerve injury, post-herpetic neuralgia, complex regional pain syndrome, refractory angina pectoris, peripheral vascular disease, neuropathic pain, and visceral pain. This is the discussion about the gate control theory of pain and its application, which would be other applications would be further detailed discussion would be made. And as a summary, it's nothing but the attenuation of the nociceptive signal transmission by a non-nociceptive stimuli, which is carried by A beta fibers, which happens at the substantia gelatinosa of dorsal horn of spinal cord. And different afferent signals can cause the gate to open and close via the interneuron, causing it to act differently. And since it forms the basis of various treatment modalities of chronic pain management, it is a very good accomplishment by us. These are the references which I look for. And thank you. Thank you for the opportunity given to me. Thank you.
Thank you, Dr. Niveta. So your presentation was really excellent. I
Thank
think talking about gate theory always difficult for the speaker. So you had made things easy with this animations.
Thank you,
So
sir.
really good animations. Yeah, it's from the heart. It's really good. Okay, thank you for making this gate theory in a better way. And I think it's now the gate has been opened for almost all. Okay, let me go for the second topic. If there is any doubts, okay, if you want to ask anything, please post your queries on the chat session. Okay, we will have the discussion at the end. By the time Dr. Niveta, you can have some rest. So we'll go for the second topic, Dr. Aishwarya. So we are going for the celiac plexus block. So whenever initially when we started our career as a pain physicians, okay, to the word when I talk, okay, I had started our pain practice. The first question they will ask, do you dispense morphine? So this was the first question. Second question they ask is, do you do celiac plexus neurolysis? So this was the second question whenever we talk about that we are doing pain practice. So I think because of ALM, sir, that celiac plexus block has widespread. So most of us know about the celiac plexus. Dr. Aishwarya, so we are eagerly waiting for you to talk, to hear your words on the celiac plexus.
Yes, sir. Good evening, everybody. What can you expect in this presentation? We are going to know about the anatomy and relations, the indications, contraindications in the application of the block, the procedure, fluoroscopic approach and ultrasound approach, and the side effects and the complication. Sorry. So celiac plexus is a dense matrix of diffuse nerve fibers and ganglia located around the celiac axis of the abdominal aorta at the level of T12 and L1 vertebra. It comprises of the celiac ganglion, superior mesenteric ganglion, and the aortico-renal ganglion. The components of the celiac plexus it essentially carries the sympathetic preganglionic fibers via the greater, lesser, and least splanchnic nerve. The innervation of greater splanchnic nerve is T5 to T9, lesser splanchnic nerve is T10 to T11, least splanchnic nerve is T12. It also carries the visceral afferents from the end organs to the spinal cord. It also receives a communication from the parasympathetic fibers via the posterior vagal trunk. In a more detail, the sympathetic innervation, it actually starts from the intermediate lateral cell column via the preganglionic fibers, which is carried along the anterior root of the spinal nerve. And then via the white rami communicants, it enters the sympathetic trunk, but there is no synapse in the sympathetic trunk. They travel via the splanchnic nerves to the celiac ganglion. And the celiac ganglion, they synapse with the ganglion cells, and then the postganglionic fibers, they travel to the end organs. So this is the visceral afferents essentially are denoted by this black line. They travel from the end organs. They are carried via the same route in the reverse direction to the via the celiac ganglion to the sympathetic trunk, and then to the dorsal nerve root ganglion, the posterior part of the spinal cord. So what does it innervate? It actually innervates the distal end of the esophagus, the stomach, the pancreas, the hepatobiliary structures, the suprarenal gland, the small intestine, and the proximal colon. Moving on to the anatomical relations. As you can see in this video, this is the cross section at the level of T12L1. You can see this is the intervertebral disc T12 at the level of T12. You can see the aorta, you can see the IVC. They are in close relation to the renal glands on renal structures on either side. You can see the pancreas anteriorly, the stomach anteriorly, and you can also find that the crust of the diaphragm separates the vertebra from the aorta. So celiac plexus is in the anterior wall of the aorta. So what is celiac plexus block? Blocking the conduction of pain through this plexus is by either depositing a local anesthetic solution at the celiac plexus or a neurolytic solution. A local anesthetic solution is an essentially a short duration block. A neurolytic agent like alcohol or phenol helps to relieve chronic abdominal pain for at least for about 6 months. So going on to the history of celiac plexus, we can see that in 1914, this technique was introduced by Capis. It's a percutaneous technique, posterior retrocrural approach to the celiac plexus. In 1947, Gage and Floyd thought it could help in relieving the pain in pancreatitis. In 1957, Jones described the use of alcohol in celiac plexus for a more permanent analgesia. In 1979, Hegedus described the importance of fluoroscopic guidance for needle placement. And in 1979, the same year, Haga and Moore recommended that even CT scan can be used for celiac plexus block. Moving on to the indications, malignant conditions, they are most benefited from the celiac plexus. The pancreatic cancer, patients with gallbladder cancer, patients with hepatic cellular cancer, and hepatic artery embolization for cancer therapy in hepatic cancer can cause severe pain, and it helps in relieving this also. And intractable intra-abdominal pain, also celiac plexus is being tried. In benign conditions, chronic pancreatitis, hepatobiliary disorder where there is a sphincter spasm, mesenteric artery insufficiency and any abdominal angina, and it can be used as a diagnostic block before proceeding to a permanent neurolytic procedure. This is a journal showing that the celiac plexus block increases the quality of life in patients with pancreatic cancer. You can see in this table that the VAS before the neurolytic procedure was very high, and after there is a significant reduction in the pain score. So what are the contraindications of this procedure? Absolute contraindications are patient refusal, obviously, and any history of coagulopathy, or whether if the patient is on any anticoagulant therapy. The relative contraindications are local infection at the site of procedure, any altered anatomy due to tumor invasion, any bowel obstruction, patients on disulfiram therapy for alcohol abuse, and any case of aortic aneurysm. The procedure approaches can be divided into anterior and posterior. The procedures can be done under fluoroscopic guidance, under ultrasound guidance, and under CT guidance. In fluoroscopic guidance, both anterior and posterior approaches can be done. Ultrasound guided, essentially only anterior approach is possible. CT guided also, both anterior and posterior approaches are done. The posterior approach, the needle can be retrocrural, the procedure can be retrocrural or anticrural. Crural in the sense whether the needle ends behind the crest of the diaphragm or in front, crosses the diaphragm is the approach. Anticrural approach can be transaortic or transdiscal. This is a small video showing the 12th rib and the L1 vertebra. This is from the behind. And anteriorly, you can see this is the celiac plexus located in the anterior part of the aorta. And this is the crest of the diaphragm. So essentially, if the needle comes from behind and stops in front, just behind the crest of the diaphragm, it's called retrocrural. And if the needle crosses the crest of the diaphragm, it's called transcrural. And if it crosses the aorta, it's called transaortic. The equipment and monitoring required for this procedure is standard ASA monitors, either fluoroscopy or ultrasound, sterile preparation and drape, local anesthetic for the skin preparation, CPR equipment and emergency drugs, a 22 gauge 3.5 inch to 7 inch spinal needle. Essentially, preloading is required to avoid any post-procedure hypotension, non-ionic contrast, and agents. Agents typically used for celiac plexus include 0.25% to 0.5% bupivacaine, 6 to 10% phenol, and 50 to 100% alcohol. Injectates such as phenol and ethanol are used for neurolytic procedures in pancreatic cancers, around 15 to 25 ml in anticrural method and 3 to 10 ml in retrocrural method. Retrocrural actually uses reduced amount of local anesthetic in order to prevent any risk of complications due to spread of the neurolytic agent to the neuroaxial structures. Triamcinolone has been tried in chronic pancreatitis along with local anesthetic. It gives a short duration of pain relief along with the anti-inflammatory action. Coming to retrocrural approach, the patient is positioned prone with pillow under the abdomen. A pillow is kept under the abdomen to increase the distance between the ribs and the iliac crest, and also to increase the distance between the adjacent transverse processes. as you can see, this is the patient lying in prone position. We draw a line in the L1 spinal process, and then it has to intersect on the paraspinal muscles, or we can take an arbitrary point 8 centimeters from the midline on either side, or it can be a line cutting the 12th rib. So this is the entry point, is a line cutting the 12th rib. And you have to introduce the needle at 45 degrees to the skin at an angulation, cephalad angulation of 15 degrees, trying to hit the L1 vertebral body. And then we have to further increase the angulation 60 degrees and then advance for 1.5 to 2 centimeters in the left and 3 centimeters in the right. This is a dual needle approach where right and left requires separate needles, and it is essentially a landmark technique. It can also be done under fluoroscopic guidance. The contrast spread is predominantly cephalad and appears to collect around the L1 vertebra posterior to the aorta. This is the posterior transcrural approach done under fluoroscopic guidance. In the same prone position, fluoroscopy is directed. Such an AP view is taken of the T12 and L1 spine. So you can see this is the spinous process and these are the ribs. In AP view, the C-arm image obtained is like this. And then there is an ipsilateral oblique tilt is given to the fluoroscopy until this transverse process merges with the anterior border of the L1 vertebra. When that is obtained, we then introduce the needle. We then introduce the needle at the lower 1/3 of the anterior border of the L1 vertebra under tunnel vision, and our final endpoint is just anterior to the L1 vertebra. You can see the contrast spread. This is the lateral image obtained. This is the contrast spread in the anterior border of the L1 vertebra. This is an AP fluoroscopic image where you can see the AP image, the final needle placement is here, and it is also confirmed with contrast spread. So where does the drug spread in both these approaches? In retrocrural, this is the vertebra, and this is the these are the splanchnic nerves, and this is the crura of the diaphragm. So coming from behind, the solution is deposited just behind the crura, and this is the retrocrural spread. If you see in transcrural, it is indicated by the pink color. The spread is anterior to the crus of the diaphragm. It is very closer to the point of interest. This is a transaortic approach. It is essentially a single needed approach. It is a left-sided technique, and the procedure is very similar to the transcrural technique, where the needle is again the AP view is obtained and an ipsilateral oblique tilt is obtained, and then a needle is inserted in the middle of an isosceles triangle formed by the 12th rib and the anterior border of the vertebra, and then under tunnel vision, the needle is inserted just like in transcrural approach, but here our aim is to pierce the aorta. So when the aorta is pierced, we can see free flowing blood in the when aspirated, and then we advance it further in order to cross the anterior wall of the aorta until no further blood is aspirated, and we stop there. And then we inject a contrast medium, and it will show a pre-aortic pulsating patch distributed along the route of aorta from T12 to L1. The final needle position is definitely anterior to the aorta. This is an ultrasound guided celiac plexus block technique. You can see the patient is positioned supine. A curvilinear probe is used, 2 to 5 megahertz. The scanning is done in short axis, and it is started from the epigastrium moving downwards. We see that this is the vertebral body. The vertebral body appears in the ultrasound as an hyperechoic line and followed by a dark shadow. And you can see the again hypoechoic aorta and the IVC here. So our aim is to first look for the vertebral vessels, and then vertebral body, and then the 2 great vessels. Then we have to scan downwards, and our ultimate aim is to find the celiac trunk emerging from the abdominal aorta. That is the first branch of the abdominal aorta. The celiac trunk divides into hepatic and splenic arteries, and that appears like a ram horn like bifurcation in the ultrasound. So we'll just see a video. In this video, we can see this is the vertebral body. Here we can see the aorta and the IVC. Scanning downwards, we see the branching of the celiac trunk into the splenic and the hepatic artery. And to obtain this image, a slight tilting of the probe is necessary. And this is a color Doppler indicating the flow of blood. And then the probe is tilted in long axis to see the abdominal aorta and the emerging of the celiac trunk here. So this is how the scanning is done. The celiac trunk, the ram horn bifurcation into hepatic and splenic artery. So it is essential in anterior approach. When entering from the right side of the probe, that is the right side of the patient, it is intrahepatic, and when entering from the left side, it is intragastric. And there have been no reported complications due to these piercing these organs. And you can see the Chiba needle inserted, and the endpoint is just anterior to the celiac trunk. When we compare ultrasound with fluoroscopy, the advantages of ultrasound over fluoroscopy, it is very cost effective. It is suitable for patients who cannot lie prone, and there is no radiation exposure. It is a simple bedside procedure. It is suitable for terminally ill patients who cannot be mobilized to the radiological suite. It's very safe. It avoids injury to the very important neuraxial structures when we come posteriorly. And there is no risk of paraplegia, as there is no spread of the drug to the posterior neuraxial structures. And you can see the real-time needle placement and drug spread visualization in ultrasound. So what are the disadvantages? It's very technically challenging in obese patients. And any people with large tumors or distorted anatomy, the ultrasound is very challenging. And the bowel shadows can obscure the view of the retroperitoneal organs, and it makes it very difficult to do the procedure when such things happen. So what are the common side effects? The most common side effect is local pain at the site of injection due to the procedure. The next most common side effect is hypotension due to the splanchnic vasodilatation due to sympathectomy, which we do in the procedure. And diarrhea is due to the unopposed parasympathetic activity due to sympathectomy. Nausea, vomiting, and chest pain is due to deposition of alcohol in the celiac plexus area, which is usually transient and relieves in an hour. And other common side effects are shoulder tip pain due to diaphragmatic irritation and back pain. So what are the complications associated with the procedure? The incidence of major complications is around 0.15 to 1%. It can be due to inadvertent injury to the structure due to the technique itself. It can cause pneumothorax because you can see that crest of the diaphragm is very near. So it can cause pneumothorax, it can cause chylothorax, it can cause renal injuries, it can cause somatic nerve injury, and it can cause retroperitoneal hematoma. Inadvertent spread of the agent can cause sexual dysfunction, groin neuralgia, paraplegia, and repeated injections can cause retroperitoneal fibrosis and pleural effusion. Infections such as abscess and peritonitis is also not uncommon. These are my references. I wholeheartedly thank my HOD, Dr. G.K. Kumar sir, for this opportunity. Thank you so much.
Thank you, Dr. Aishwarya. Okay, thank you for enlightening us on celiac plexus. So now we have few queries in the chat box before we go for Dr. G.K. sir. So let me discuss something about celiac plexus. Okay, the first question is, okay, ma'am, you have talked about retrocrural, anticrural, right?
Yes, sir.
So which one do you prefer, ma'am, in clinical practice?
Sir, anticrural, sir.
Okay, anticrural, which one you like to do, ma'am? Is it the classic or transaortic?
Transaortic, sir, because it is single needle technique and it is very close to the area of interest.
Okay. So thank you, ma'am. Thank you for answering the first question from ALM, sir. So sir has asked, so is it allowed to do transaortic approach to celiac plexus? So thank you, ma'am. So it being a single needle, so no need for multiple entries. So a single needle, exactly we go just anterior to the aorta. So which is the usual location for your celiac plexus. That is the most preferred technique by us. Okay, the only problem is we should rule out aneurysm and atherosclerosis. Though it's a single procedure, it carries its own risk. The thing is about bleeding. So what will happen if you puncture aorta? So it won't bleed. You are going through and through, na?
Yes, sir.
So-
There are very less reported cases of.
Excuse me, Chairperson, sir.
Yes, sir.
Please, let us finish all the three and we can have a whole discussion at the end.
Sir, we have some ample time. There on GK Kumar's
Yeah.
topic, sir, things will close off.
But anyway, that
Okay.
once the lecture is over,
Okay.
everybody can combine and they can answer.
Okay, sir.
Maybe
So we can complete that last one question and we'll go. So which reagents, what is the neurolytic you prefer?
Neurolytic alcohol.
Okay. So how much percentage you like to use it, ma'am?
50%, sir.
Okay. What about phenol, ma'am?
Phenol, we are not using. So
Okay. So usually we can make 6% phenol. So it's easy to prepare it. We have to prepare it every time. So that's why it is not commercially available. Okay, ma'am. So the phenol use should be around 6%. So that can be prepared at the bedside itself. So thank you, ma'am. Thank you, Aishwarya, ma'am. We'll be joining back because celiac plexus always carries a lot of queries. So we'll join back at the end. So Dr. GK sir, so I invite you to start your topic on management of chronic pain.
Yes. Can you see my slides, Guru?
Yes, sir. Yes, sir.
Are you able to see?
Yes, sir. We can see.
Yeah. Very good evening to you all. 1 minute. Very good evening to you all. It's a wonderful experience to sit in front of the great stalwart of anesthetist and administrator, and he is the great multifaceted personality, and my good friend, I proudly can say, is my mentor and good friend, Dr. Fondedly, everybody says the ALM, sir. Thank you, sir, for giving the opportunity, and not only for me, for my team. And here, with the thing, I have to thank the Pudukkottai City branch for the welcome you for the Pudukkottai Budan. It's a nice word, the coined by the most probably the man behind it, the ALM, sir, only. Pudukkottai Budan, nice rhyming word, and it is getting popular throughout India for a persistent effort and keeping the standard a little bit high for that. And it is a unique one of blending the youth and other well as the little bit experienced people to share the topic and mainly focus on that postgraduates. It is not meant for the who's going to do the blog tomorrow, who is going to learn about the subject and going to come out with a little bit confident once he finishes the career mostly. This topic was selected, the how many questions asked in the university exams in the field of pain, chronic pain, and we discussed with that, and finally sir approved these 3 topics. And coming to that, thank you for once again all, and we'll also a little bit, I have plenty of time. My people has leave a lot of room for me to discuss. So I'll start it with a lighter note. Those who are subscribed for Nizara definitely will notice this mail pop up with this. Did Nadal played under anesthesia? This is the famous anesthetist. Now he's become a very good teacher, Dr. Hadzik, and excellent teacher with the great techniques of teaching some methods and gadgets. Hope everybody will receive that. What it shows, the Nadal played with some kind of the nerve block in his record-breaking French Open final. Before the semi-final, he himself declared, I don't want to play with this injured foot, rather than I want to go out of the tournament. But this, we are not going to discuss whether it is right or wrong, but somebody made him to play by giving the drug, something like that. We played with no feeling in the foot, with the painkiller injection in the nerve. The foot was asleep, and he played and he won the record-breaking French Open final few weeks ago. After that, he came out of that Wimbledon. That is different kind of story. But what my thought is going to be finally, this man discussed deeply that what happened to the Nadal. Then physicians behind the Nadal, so Spaniard people, so many people are discussed, and finally they concluded the Muller-Weiss syndrome. That is something like the navicular bone is due to the repetitive strain injury. It is degenerated, and some of the anesthetists gave the block to make for appearance of the thing. So sorry. So with that note, the chronic pain, what in early days thing is only about the cancer pain. When I started the pain practice, people will come and ask for that. As he said, can you give celiac plexus, sir? Can you take care of this patient with a little bit of morphine, oral morphine or something like that? Can you give the epidural block for this patient? Though only we started only worried about only people thought we can deal with the cancer pain. But now it is extended like anything. This the previous code denotes the list is endless. Now it's entered to the sports injury also that. So the chronic pain not only restricted to the cancer pain, spinal related pains, neuralgias, especially trigeminal neuralgias and post-herpetic neuralgias, and musculoskeletal pain. And another thing is that, and next is the sports injury, not the least, but now it is we are getting popular to the sports injury. We are having a lot of persons as a sports injury, not only the professional sports, habitual sports, runner, joggers, all the people are getting and approaching the chronic pain specialist. So it is the field is extended. Previously, it is confined only to the cancer pain. Now it is extended to the many fields. So the chronic pain management, this was like this. Still, it is like this. When the patients landed to the neurologist, they look only at his neuropathic pain. When the patients landed to the psychiatrist, they will look at the patient having depression and other things. When the patients landed to some of the surgeons, they'll only look at the anatomical lesions. If we remove that anatomical lesion, the patient will become painless. That is their part. So everybody is thinking like that only. Only the pain physicians knows that no, this is not the tail-like structure. It is not the fleshy muscle-like structure. Holistic approach looks that it's a big animal, that is the giant animal, that is the elephant. So the pain physician concludes because of his wide knowledge and other things, he can manage the pain and in proper way. So the another 20-25 minutes or more, so not more than 30 minutes, my key points will be the covering the pain definition. Unless you understanding the chronic pain little bit, you cannot beat it or you cannot treat it. So what is the management options available? That's the main topic. That the morely my presentation will be wobbling around the interventional procedures, stage by stage. Finally, I throw more lights on the interventional procedure because this is the most important one in chronic pain management. So coming to that pain definition, it was revised in 2021 last by IASP. The pain, if you ask the patient, they will describe in so many things, but academic definition, the one, and it is a universally accepted. Previously, it was defined 1979. It took long 50 years to redefine this, and finally they settled with this statement. So unpleasant sensory and emotional experience. Definitely, it is not only related to the sensory. Emotional part is also there. It was that still 1979. They have not changed anything like associated with or resembling that associated with actual or potential tissue damage. What does it mean? It may be associated with, in simple words, otherwise, it may be associated with tissue damage or may not be damage or potential ongoing damage, or in few days or few months, the damage would have been shown that. So whatever may be that, it is the unpleasant sensory emotional experience patient is undergone right now. That is the take home point. Pain is a personal experience. You cannot measure it. You can score it by again asking the patients patients reporting only. You cannot, just like your blood sugar, BP or thing, you cannot measure it under desired thing the patient is suffering with. It is a purely biopsychosocial factors. What we thought is the pain is the, for producing the pain, there should be the nociception. But chronic pain and nociception are entirely different, especially in chronic pain. You can understand this thing by this small picture. See, these are the thing. This is the one man, I took it in the Malaysia, that is the, he's hanging in the, that was the very famous in type or something. This is one of my patient, and this is, it is not my patient, of course. You can see that he's met with some RTA, something like that, on Saturday night after his regular activities. So somebody is consoling him, and this is very, we'll start with this fellow. This is very obvious reason. He has some injury, obvious agony is there. Even with the consoling that the patient is suffering with the pain. So nociception is there, injury is there. Look at this patient. You cannot say any abnormality. Can you see that the patient is suffering with the pain for more than 1 year, and he quit his job, and he went for some psychological depression and strained relationship with the family. Can you notice that nothing? He's having complaint of pain over the face for the past 6 months, that is trigeminal neuralgia, and he came from Gulf, and we treated him, and he gone back. And again, 3 years back, he came, and after the period of 6 years, this second time we did it, radio frequency ablation. I'll come to later what we thought. This is what, but the take home message here is the patient nociception is there, obvious nociception is there, pain is there. There is, you cannot see any nociception obviously. No, nothing is could be seen, nothing is MRI, CT, everything was normal, but the patient is still suffering with the pain. Here, the fair amount of the nociception is there. See, the skin is hooking, the hook is hanging in on the hooks. So you cannot imagine what could be the pain. Do you see any sufferings in this space? He's enjoying that, he's nicely posing to me. That's the thing. So nociception, if it is there should be pain. It is not at all, need not be necessary. If the patient is suffering with, never ever search for the nociception. Of course, you have to do the proper clinical examination, but unless the nociception, you don't accept the pain is totally wrong. The nociception, different phenomena, pain is different phenomena. That is the take home message. At least if you carry this message, I'll be very happy that. And if you want management of the pain, you have to know the 2 words. What is pain modulation? What is pain sensitization? I'll explain in 2 simple sentences. Pain modulation refers to the process which the body alters a pain signal and it is transmitted along the pain pathway. So our body try to alter the pain signal and try to reduce the intensity. Some way it is reduces the pain conduction, some way the pain perception. That was gate control theory. One of the things it was that some descending fibers are there. All the thing I'm not going to dare explain that. You can read from your standard textbooks. So pain modulation is the help us to reduce our pain perception or pain feeling or reduce the severity of the pain. Whereas the sensitization occurs is in chronic pain. That means enhances the pain perception. That is the increase the gain of the nociception. This is the just opposite that. This is the most important thing happening in the chronic pain. The pain, acute pain, becomes chronic pain by means of the sensitization. It occurs in the central level and the peripheral level also that. So what we are going to do, the pain management, simply enhance the pain modulation, pain control mechanism. You just enhance the inhibitory process, all the things are, or protect the inhibitory process, the modulator process, and make that decreases the sensitization process by available drugs or any techniques and other things. So keeping the modulation and abolishing the sensitization, try to abolish the sensitization, key point of chronic pain management. So small things are to understand the things little bit more. So this is the normal pain conduction pathway. The stimuli is there, and it is going to get conducted through the dorsal root, and it is going to ascend the spinothalamic duct, and pain is perceived. The descending fibers are inhibitory fibers somewhat control the further transmission. So that is the thing. This is a natural phenomenon. The pain is not much previously felt. It is trying to control. These are all the things, our natural mechanism. Now, this is the nerve dysfunction occurs, whereas the increased release of the glutamate tank, the same kind of the stimuli will become propagated, and a lot of things will be released. Not only the amount and the repetitive stimuli will be there, that will be again pain amplified here at spinal tract, and the more pain will be persistent, whereas the descending parts are not going to be useful in this case. What is the ultimate result is the thing? So persistent stimuli, the inhibitory pathway is not good, the induction of the central sensitization, that means ultimately lead to increased pain perception. Now the pain has become chronicity. Now it has the chronic pain, as the patient already suffering with the chronic pain. There won't be any stimuli or minimal stimuli, for the patient will have the increased amount of the pain. So what is the sensitization happenings? What is the clinical implications? It will increase the increased intensity of the pain. For the lesser amount of the pain, previously patients can suffer with the smaller amount of pain. Now this increased intensity of the pain will be there for the same exercise or for same stimuli or for walking. The patient, not only the disease is getting worse, but because of the complexities occur in the central, due to the central sensitization, patient is having increased intensity of the pain. Then the increased area of the pain also, the pain will spread more areas. Increased duration of the pain also there. Increased tolerability, decreased tolerability will be there. It is due to the psychological changes, development of the psychosocial problems. This is inevitable. And now the pain becomes non-responding to our conventional analgesic. That is the most important clinical sign. The pain has become completely converted into the acute to the chronic stage. So what is the symptoms of the chronic pain? Is the pain will be again said that the chronicity of the pain will be the neurodeficit will be there, and pain will be the neurodeficit area, allodynia and hyperalgia. Hyperalgia means the smaller stimuli, bigger things will. Allodynia, non-painful stimuli will become pain. If you touch the patient will jump on the pain. And this is called allodynia. All these things are due to the sensitization problems, characteristic of sensitization mechanism. The character of the pain will become burning, shooting, electric shock, and creeping. Patient will describe in so many things. The associated symptoms, numbness, tingling, pruritus, feeling of pin and needles, the classical things will be presented, especially diabetic peripheral neuropathy. And sympathetic mediator pains on redness, edema, painful movements, decreased temperature, fall of hairs or shining hairs will be there, especially in complex regional pain syndrome. These are all the symptoms of the chronic pain. Now, how we are going to manage the chronic pain? As I said, you have to retain the inhibitory fibers thing that is called pain modulations and inhibit the sensitization process. It can be, as this is the pain pathway common things, and it can be here is the such giving something like you can give local anesthetic solutions, the lidocaine patches there, especially in post-herpetic nerve, not in the hands. I mean, saying just as a representation purpose here, you can apply the local patches and or capsaicin, all the things are things there to act at this level. And you can also give some drugs which is acting in the central nervous system, which is drugs. Other thing is the dorsal root ganglion. This is the thing you can give the drugs also, that especially the promoting the descending pathway activity, as well as the some interventions. So these are the areas will since you are doing this kind of the things, it is called a multimodality. You can give the peripheral nerve block to prevent the pain conduction upwards. So what is multimodal approach? So if you ask the university questions, you have to write the chronic pain, what are the problems of the chronic pain, and what are the basic things happening behind the chronic pain, and what is the multimodal approach. It is not nothing but simply pharmacological agents, interventional methods. It is a combination of the all things is called multimodal approach. Multidisciplinary approach is different one, and multimodal approach is the different. This is the multimodal approach. Multidisciplinary is the different kind of the psychiatrist. other well as the orthopedics, all the things are multidisciplinary, and again alternative medicine. Whereas the same patients receiving pharmacological methods, intervention methods, all the things called multimodal approach. You are approaching them, you are treating the chronic pain in different modes of the pain pathway. That is called multimodal approach. What other things are available in multimodal approach? The pharmacological agent, of course, the drugs, the main step, factor for chronic pain management. The main thing in chronic pain management. The next is the interventional methods. When the patient is not able to manage with conventional methods, we have to choose for the some of the things which is interventional methods. Why the interventional method is popular? No? Almost 25% of the 25 to 30% of the patients are suffering with not able to tolerate the pharmacological drugs, or not able to take the drugs, or it is insufficient whatever the dose you are achieving that. So that is the interventional pain methods comes in handy to increase the quality of the pain relief and lead the perfect life, or the quality of the life to be improved. For that, the interventional pain methods coming helps a lot. And of course, without physical and rehabilitation, these two methods will not be fulfilled, or it will not be 100% successful or near successful. So physical rehabilitation method is the method which has to be combined with pharmacological agent, whether you are choosing the pharmacological agent, whether you're using the interventional method. This is the most important method of the multimodal approach. And so, of course, psychological intervention part and parcel of the multimodal approach. You cannot separate all these things from these psychological interventions and rehabilitations, all the things. It's a must over whatever the treatment patient is getting that. And right now we're getting the popularity regenerative medicine. I'll come to later what is regenerative medicine. And not the least, if it is possible, the patient can be sent for the alternative medicine methods. Tai Chi is the one of the method is very popular for especially the fibromyalgia treatment. It is nothing but Chinese some physical exercise program that may be useful in some of the patients, and studies also good for that. And I don't know anything about that. I think just for completion sake, I am completing that. So the multimodal approach is consisting of the various methods of the management of the pain by means of one pharmacological agent. Second is the interventional method. Third, and the physical rehabilitation, psychological and regenerative methods, and complementary things. This is the multimodal approach. The single method will not be useful for chronic pain because of its complexity of the pathophysiology behind it. So now we are coming to the what are the pharmacological agents. There are plenty of the pharmacological agents are there because of the complexity of the pain. Especially the chronic pain, the peripheral nervous system. I told the sensitization, central sensitization, and modulations. So these again we have divided into the drugs which will promote the descending modulation. The drug will inhibit the sensitization, whether it's happening central, whether it's happening peripheral. So this is the thing, basal idea of this site of the action of the pharmacological agents. The drugs which promoting the activity of the modulation is the anticonvulsants, opiates, and tricyclic and SNR. Opiates are a little bit controversial in that, but definitely it may help us to adjuvant in the main component, the anticonvulsant, tricyclic antidepressants. Sensitizations, again the anticonvulsants and the NMDA receptors are there because these will promote the sensitization. So NMDA antagonists are very much useful in some of the cases of especially chronic pain by acting through the inhibiting the central sensitization. Peripheral sensitization, again the local anesthetics, topical agents as I described, local anesthetics, local anesthesia, lignocaine patches are the topical agents of the capsaicin, and the anticonvulsant drugs and tricyclic. So the most important, the anticonvulsant is the drugs which will act in the all level, that is the descending modulation as well as the sensitization. So if you are without writing this anticonvulsant and tricyclic antidepressant, the pharmacological agents will not be. If you write these things alone, there is the almost cover the 70% of the pharmacological agent for the chronic pain. The next is the where it is acting. Again the same thing, peripheral sensitizations acting the sodium and calcium channel. Again the two drugs which are there, what is the anti inhibitor or the drugs which is acting through this called The treatment of central sensitization is the anti-calcium channel block, all the sorry, I have that. So all the things are anti-epileptic drugs. So, one minute. Yes, the anti-epileptic drugs will act through the sodium channel blocker and calcium channel blockers. The treatment for the central sensitivity against the NMDA antioxidant, again the calcium channel blocker. This is the site of action where it acts in the restoration of the descending pathways. The tramadol is the opioid which is acting especially on the descending inhibitory pathways. So the mechanism-based analgesics, the mu receptors, as you know, that opioids, the most one thing. Mild-acting tramadol is also the opioid category. Sodium channel blockers against the lignocaine and the anti-epileptic drugs. The calcium channel blocker against the GABAergic drugs, which is a gabapentin and a pregabalin drugs. The neurotransmitter level acting is the antidepressant drugs. The clonidine, again, one of the drugs which will act through the adrenal receptor agonist that will be useful in some of the cases of the chronic pain. So enzyme inhibitions, you know that NSAID is acting through the drugs. So again, the gabapentin drugs, which these are all things mainly used for the neuropathic pains. So gabapentin, pregabalin, voltage-gated calcium channels, the carbamazepine and oxycarbamazepine. This is the sodium channel blockers, which is very much useful for the trigeminal neuralgia. The tricyclic antidepressants will have the part and part of the things. We cannot, without these three drugs, we cannot treat the chronic pain. So the pain medications per se will come under the anti-neuroleptic, anti-epileptic drugs, antidepressant drugs, NSAIDs, and other drugs. So the one is the anti-epileptic drugs. The most commonly used the two drugs, gabapentin and pregabalin. And the problems, all these things are the hangover will be there, and the constipation is inevitable with all these drugs. And you have to be very careful when you are selecting these drugs for longer period. You have to keep checking the liver functions frequently, at least once in 3 months. The carbamazepine is the drug of choice for, you know, the trigeminal neuralgia. If you have the good result with the therapeutic benefit with the carbamazepine, that goes also the clinical diagnosis of the carbamazepine. And oxycarbamazepine, little bit safety measures, safety profile, and it is hepatic function is good, and little less hangover will be there. And when you are suspecting and when you want to give the longer duration, oxycarbamazepine is one of the choice for that. And phenytoin is the again the sodium channel blocker, and it will help in the chronic pain. Lamotrigine and topiramate we are rarely using because of this safety profile, not favorable safety profile. So then again, I come to the antidepressants. The amitriptyline, imipramine is the old antidepressants, but they have the safety. They are not good for the patients with the ischemic heart disease or conduction blockade, especially the old age group. So that's why coming the SNR is serotonergic noradrenaline reuptake inhibitor. The famous one is the duloxetine, venlafaxine, milnacipran is the most important drugs we are using. That duloxetine is the very famous for and FDA approved drug for the diabetic neuropathy. And NSAID, you know, the lot of NSAIDs are the most important drugs what we are using, the COX-1 and COX-2 inhibitors we are using that. Among the selective COX-2 inhibitor is the Epidural is the one of the drug which is little bit safety profile. It doesn't have the great thing, but it is available NSAIDs. It has the little bit of less platelet activation and less little bit safe for the age group. That the more again the indomethacin is the drug which is mostly used for rheumatoid arthritis cases. That though so NSAIDs. Again, you have to be very careful when we are giving the patients with the older age group, especially with the systemic disorders of the diabetic and hypertension. Need not to give not more than a week. And you have to take care of the other parameters like is renal parameters and hepatic parameters and coagulant parameters also. That this newer ETC, I mean COX-2 inhibitors also have some cardiac issues also. Thus it's better to avoid these kind of the things. So though among the available things, the most commonly used one is the Epidural and etorocoxib, but other countries are not available. In our countries, we are widely using that. And indomethacin is a little bit safer than the etorocoxib, and we can use for that. our indomethacin is a little bit safer. So NSAIDs, you can classify the NSAIDs among that. Not much useful. You have to very selecting the use, and NSAIDs are not at all going to be useful in chronic pain because the pathology and physiology is entirely different one. So the opioids is the main cogwheel of the pain, chronic pain medications, and the most important thing everybody will use it, the ultra famous one, the tramadol, nothing but tramadol. Tramadol. So this is the most important drug. It not only acts through the opioid, it has the acting through the descending modulation also. It inhibits that. So, it promotes the descending modulation. So the chronic pain is the drug of choice is the tramadol. Nothing other will be preferred by all the pain physicians. Tapentadol is one of the recent drug which has the opioid-like action as well as the antidepressant action, but the clinical effects are not much expected as we anticipated. But it has the dual action. It has the opioid as well as the antidepressant effect. Codeine is the most important previously used one, and morphine and buprenorphine. The morphine is the mainstay for the chronic pain, especially the cancer-related pain, and buprenorphine, because of its availability in the other forms, getting popular. So these are all the common opioids we are using, the tramadol and morphine and buprenorphine. What are the other drugs we have? Of course, the paracetamol and part of the thing when you have using that mild form of the anti-inflammatory drugs, and ketamine and local anesthetics. Local anesthetics can be used as a infusion also, the Zylacard for the chronic pain, especially CRPS. And medical cannabis is coming up. If you're coming with a lot of research is going on, and it is one of the recent one. If the medical cannabis coming, and it will be the boon to the not only the chronic pain as well as the acute pain and resistant acute pain also that. So these are all the cover of the anti-epileptic, antidepressants, NSAIDs, opioids, and other. The 5 categories of the drugs will cover all pain medications for the chronic pain. It includes the completely cover the pharmacological agents used for the chronic pain. The next, not the little bit on sustained release drugs, because these are all NSAIDs, all the things are there. Sustained release drugs are now available in the market, but it has a limitation of the safety profile. So you have to be very careful when selecting the sustained release, especially the NSAIDs. But the narcotics are very much useful, because previously we used to give every 4th hourly by time clock, by every 4th hourly. That is very difficult to follow this patient. Nowadays we have that 12 hours morphine drugs are there. The technology improved us the acceptability of the drugs to the patient. Patients will be very happy to take every 1 tablet morning and night only. So the sustained release tablet, especially the oral morphine, is a boon for patients. And if we have the pages and especially the buprenorphine, so once a week, patients can change the only thing. Fentanyl not much going to be useful in chronic pain, but the buprenorphine pages is also available for as a sustained release for the chronic pain, especially the cancer patients. So this is various uses. Other things, the osteoarthritis pain and low backache pain, and the treatment of the opioid responsive pain conditions which are not adequately respond to the non-opioid analysis. So it can be not only reserved to the some of the very selective cases also that it can be used. So coming back next to the interventional pain method, the most important member of the chronic pain management. What do you mean by the interventional? Interventional modalities are very big list is there, but I'll try to make it within these 8 categories. That the neurolytics blockage, you know that once you're giving the neurolytics blockage, the celiac plexus block, it is not the neurolytic blocks of the nerve, but it is a plexus block. So anywhere you blocking the conduction of the nerve fibers, that is called neurolytics blocks. Usually, suppose you are giving maxillary blockade, that is called neurolytics block. If you are giving some drugs which permanently or temporarily suspends the conduction of nerve fibers, that is called neurolytic chemical block. So the first thing is the neurolytic block. It should be guided. What do you mean by guided? I'll come to later. What do you mean by guided? I'll come to later. And the most common one is the epidural steroids we are giving as an interventional model, especially for the discogenic, the pain or back pain arising from the disc. Then musculoskeletal intervention, as I said, the most nowadays we are getting more patients of the musculoskeletal intervention, usually done by ultrasound guided procedure, because suppose for an example plantar fasciitis, this is the thing which can be dealt easily with musculoskeletal. This is one of the musculoskeletal intervention. Ultrasound guided interventions can be useful for these patients. And you have the tennis elbow, you have the shoulder joint, knee joint, everything will come as a musculoskeletal intervention. And piriformis syndrome, so many diseases are there. This musculoskeletal interventions are going to help us. So this is also one of the intervention modality. And of course, ozone therapy is the old one. Now it is not much used, but it is for the completion sake, I mentioned as a ozone therapy. That chemical ablation, what do you mean by the chemical ablation is that, as we discussed about the celiac plexus, if you are putting the drug in the celiac plexus by some chemicals which will ablate the conduction of the nerve fibers or destroy the fibers which we installed. That is called by installing the hypertonic. Saline one is the one which is not much useful, but phenol and the alcohol. Alcohol is the ethanol. Here the alcohol is the ethanol. So by putting some chemicals, by doing some guided procedure, selectively blocks or ablate the nerve fibers there. That is that way we are reducing the pain conductions. So that is one of the procedures that is called chemical ablation. Common one is the celiac plexus chemical ablation, alcohol chemical ablation, phenol chemical ablation. All the things will come to this category. And of course, the refined way of doing that chemical ablation, now we get radio frequency listening. By giving the selective radio frequency listening, putting over the nerves, we are blocking the nerve conductions somewhat. There is the various methods are there: conventional radio frequency and cooled radio frequency and pulse radio frequency. All the things are there, but all coming under the category of that. This is the most important member of the interventional modalities. Nowadays, lot of modalities we are treating with radio frequency listening. One of the most common thing you can mention as a radio frequency listening of the trigeminal ganglion for trigeminal neuralgia. The neurostimulation, spinal cord stimulation, and the first lecture talked very nicely about the spinal gate control theory and its wobbles around that theory, and neurostimulation and the spinal cord stimulation will be also the coming up, and it is expanding like anything. Then intrathecal drug delivery. These are the targeted delivery drugs. When the drug is taken 300 milligram, if you are giving to 0.1 milligram in the spinal level, the effect will be very high and the patient will be very comfortable. You have the microprocess controlled devices, are just putting a small wire into the spinal cord of the patient, and you put a small delivery unit in the patient's and it is controlled from outside by various calculation, and the drug is very, very tiny drugs are delivered throughout the day and throughout the month for making him pain-free. So the interventional modalities, again, I come to neurolytic blocks and epidural steroid, which is very commonly used, and still we are using that. And musculoskeletal interventions, example, plantar fasciitis, shoulder joint, knee joint, ozone therapy for producing the pain relief. The ozone is nothing but the oxygen, which is injected into the painful areas. It can be injected in the muscles, joint, and disc also that. And it is not much useful now, but anyhow, you can mention it. And chemical ablation by putting the alcohol or phenol hypertonic saline over the nerves on the particular area of the thing. And radio frequency listening is the finer way of refined way of producing the lesion in the nerves. And neurostimulation, spinal cord stimulation, you know that it is based on the gate control theory and intrathecal pump delivery, especially the morphine pump and baclofen pump. If you know that also based on these interventional methods. So coming to that, these interventional methods, what do you mean by the guided procedures? Mostly the fluoroscopic guided. Fluoroscopic guided means that the CM guided. We never do any procedure under blind. So all the, because of the preciseness we have to produce, and we have to produce the good results, and we are installing that alcohol or the things. We don't want to install all other things in unwanted place to produce some new pain or something like that. That's why it should be precise and it is targeted. That's why always to be done under the fluoroscopic and USG guided, and it is very getting popular, and everybody is having the ultrasound machine in the pain physicians OPD. And CT guided is the another thing we can do that. And advanced one, the robotic arm is also available right now. It is, I was previously associated with one of the government hospital, multi-supervision, where we have the Perfint. And this is the thing, just for you can write it out for a purpose. And CT guided, we have to keep this thing. This is called the Perfint, and you calculate all the things where you want to give, where the arm will come exactly over the patients, and one slot will be the just push the needle along the shot, and the pins will. But this calculation will take another half an hour, 45 minutes to do the pilot film and all the things. So interventions modalities are mainly the fluoroscopic guided or CM guided. Next thing is this ultrasound guided, CT guided. The three things are very commonly used, and robotic arm guided and aided also available in nowadays. So some of the cases to make you understanding more about what are the interventional cases. This is the thing I want to a few 5 or 6 cases. That's why you can understand what are the interventions. So this is the ilioinguinal ESG guided block we gave for the patients who gave the 21 year operated for acute appendicitis. Again, the patient have persistent pain over the scar. This is the post-chronic, post-operative scar pain due to the nerve entrapment, maybe the ilioinguinal, iliohypogastric. The simple ultrasound guided trial block was given, then repeated block for 3 to 4 weeks we gave with a little bit of deposit, and patient was treated like that. It was the first case reported in our pain clinic where I worked 5 years before. Superior hypogastric plexus block, which is the useful for the pelvic pain, maybe due to the cancer and non-cancer patients also. That is the one patients we had the pelvic pain for 15 years, the operated twice, one for hysterectomy and again laparoscopic, and again patient went for a diagnostic laparoscopic, but still persistent pain. All the investigation opinions revealed nothing. This is the one cancer. Now you remember the pain definition. Patients perception pain is we have to accept. The ongoing neurological problem is there or not. This is be very difficult to convince the people, but the patient is suffering with the pain. That's why pain is not relieved by the regular analgesic. One of the things which is clinically shows the signs of the chronic pain, branded psychosomatic and strained facial familiar relationship, and we gave the superior hypogastric plexus. For your thing, small thing, the superior hypogastric plexus over the pelvic area, exactly in front of the pelvic promontory, right and left. So this is the area we have to give some drugs or chemical neurolytic drugs. So it is done under the fluoroscopic guided. The needle is passing through that, and we gave the contrast. That means I'll come to that. What are the contrast we are using? That this is to conclude where the nerve is, where the drug is not in the drug is in the drug, the needle position is perfect, and it is not in the vascular also. If you are if your needle is in the inside the vessel, if you're giving the contrast, the dye will wash up and you cannot see the persistent shadow of that. So the pattern should be noted, and it should be persistent also. That denotes it we are in particular, we are in correct plane, we are not in wrong plane, or that is intravascular. So that is why that contrast is injected. It is the must before doing any procedures. So final confirmation is this again, this has to be here, and we are putting the right and left needle, and after that final the contrast position is very much satisfied where we want to do that. So next is the inferior hypogastric plexus. Suppose if the patient having a prostate or a rectum, he is having the pelvic pain around the anus, or little bit of deeper thing, we can try this one, inferior hypogastric. Sorry for the poor thing. Just we are putting the needle in the S1 foramen, and we are giving the contrast, and finally we give the chemical neurolytics. And this is the one of the case intercostal block ultrasound guided. Again, I told all the blocks should be conducted either by the ultrasound guided or by the fluoroscopy. So this is the one of the musculoskeletal block. We can give that under ultrasound guided. This is the patient we gave that. This is called again considered as the post-scar pain, chronic post-scar pain. So 15 years old boy developed pain after hemangioma left inframemory area, no local pathology, radiological investigation, everything was normal. Pain is not relieved by analysis, considered malingering and sent out for aggressive behavior due to somebody touches him, he screamed with the pain. We gave the diagnostic blockade of the ultrasound guided intercostal area of the 2 areas, and finally later we gave the posterior approach because the patient doesn't allow to touch anything. This is after giving 2 blocks, is just allowing to touch. You can see the ultrasound machine behind it, and after that we serial blockade relieved his pain. So again, this is I explained that I saw the patient previously. This is a facial pain for the 10 years during not relieved, was not tolerated, not able to do day-to-day activities. We treated him with radio frequency ablations. This is done through the foramen oval. You can see that the foramen oval, small thing is that we are inserting the needle into the foramen through the fluoroscopy guided, and finally we confirm it and through the thing, and we have the radio frequency machines which have the, just like your nerve stimulator, we are stimulating that sensory and motor stimulation can be done, but your peripheral nerve stimulator, you have the only the motor stimulation. Here we have that radio frequency machine. We have the extra benefit of facility of testing the sensory. That way, the patient, the needle will be exactly close to the where we want to produce the lesioning. And this is the thing. Again, we have taken the fluoroscopy as well as the CT. Also, we have taken one of the some of the machines we can take the CT guided. CT film also we can take after confirm the final position. So this is for just for academic purpose. I took it. So the needle is exactly going there where the trigeminal ganglion will be there, and all the things will be done. Then once confirm it, we are giving the radio frequency listening. So again, this is the thing. Not only we are doing now, our field is expanded into the spine also. That this is the collapsed vertebra due to the one of the cancer conditions. The patient went for. I just think he had a multiple hanging attempts and suicidal attempts are there. The patient landed in our hospital for this thing, and we gave the vertebroplasty done. That is the passing through the needle and fluoroscopy guided and passing the cement. This is the cement. This is not the dye. It is a cement which is stabilizing his spine not to collapse, and the patient was able to stand, walk after the procedures the next day. That so. And again, the celiac plexus was very much discussed about that. It is meant for the cancer patients, very much useful for cancer patients, non-cancer patients, chronic pancreatitis also. This can be used. Pain is not really, this is the retired school teacher, pain for 3 months and a celiac head of the pancreas, severe pain and pain not relieved by the drugs, and we give the block, and you can see the smile face after immediately 2 hours after the block is sitting nicely in the post block carry area there. And this is the thing, again, it is conducted by the fluoroscopy, CM guided, CT guided, any the needle is passing through the L1 vertebra. Again, the contrast is injected, and we the contrast is persistent and it's perfect in position. That's why we gave the neurolytic position. Patient uses the alcohol, absolute alcohol or ethanol. You can say that it's usually anything around 50 to 100% can be given. The volume depending upon the how much you are giving. Usually we'll give 10 ml on each side. So this orofacial pain is a very, very common phenomena in our country, and for especially in government setup where the cases, a lot of cases will come with screaming with all the time. They're having the hand on his cheek, right or left, and they will very much miserable look. I mean, you cannot describe that the way they are looking at and other things. Nothing will be, because this patient cannot take oral tablets also that. So we decided to give the block. When we are coming to OPD, we'll just go through the records. Most of the patients are post-surgical patients. They are taken something like that. So we don't worried about the coagulation profile also, that we'll just put the needle and block the maxillary or mandibular nerve depending upon the pain area. So it's a very simple block. You can do that, just palpating that the needle. This is the one block I'll go that blind technique. And before doing, but that also I will do when we are giving the alcohol or phenol, or usually we used to give alcohol only. I'll do the fluoroscopic confirmations. On arrival, we just put the needle and we'll give 1 ml of xylocaine, whatever the things, and the patient will be very happy. Next day, we'll post him on the permanent neurolytic procedures. So this is the way we have to. Some of the patients we use radio frequency ablation also by doing the same technique, by putting the radio frequency machines and other things. But this should be done only under the guided procedures. So the stellate ganglion, again, the very common procedures being done, so it can be blocked by the ultrasound guided, and this is the radio frequency ablation of the stellate ganglion used for the phantom limb pain. This is one of the very interesting patient. That patient, we gave the stellate ganglion, but the patient had the pain relief was very partial. A few months only, again landed with our clinic with the pain. And this patient, we gave the spinal cord stimulator, cervical spinal cord stimulator. After putting the trial needle and other things, you can see that the spinal cord stimulator again working on the theory of the gate control mechanism. We have created a small pocket, and post-operative, we can see the small, just like pacemaker, and the wire is going through that. And we have calculated the leads are there. With the external calculation we can do. We can do lot of calculations and permutation combination to that. The strength of the current, right side, left side, all the things, and how much the pain relief is there. And finally, we leave to the patients to go home with the external controller, a small dial, a small, just like the cell phone, he can have that. So all of these can be, patient will be monitored. This patient was kept almost 8 to 12 months. This neurostimulator, the spinal cord stimulator was there. Later we removed him. Now he is happy without much pain. So this is one of the CRPS, complex regional pain syndrome cases, which is very commonly we are seeing that. Very difficult pain to relieve that, but we can try little bit on that. This is the case of the arm pain for the 1 year duration post mastectomy, operated twice for cervical burst. Because the patient had the arm pain, the surgeon did the anterior discectomy. Patient was not relieved pain. Again went to the another institution. They did the posterior discectomy. Again came back that then they see the some kind of the swelling in that. You can see the closely the small scar will be there. They took biopsy here. So then rheumatoid or something like that they suspected, but the patient no analgesic, no pain relief with all the things, avoidance of the things, and went for depression. Came immediately. Then I took the picture, so you can, anybody can say this is the CRPS. All the things are, nail changes are there, shiny, sympathetic mediated changes are there. It is a spotter for CRPS. So what we did on arrival, we count that stellate ganglion block and repeated stellate ganglion block produce excellent release there. Again, the most important thing, the epidural, but we are not going to give the simple epidural drugs. Another intervention is the epidural injections, but we are not going to give the simple epidural. We are the targeted epidural. What do you mean by the targeted? It is on the where the drug has to be reached. We are targeting the lesion and we are giving the drug. It is for just, I took the, for understanding of the more, I took, this is our conventional epidural. This is the interlamellar phase. This is the one spine. This is the sacrum. This is the L5 spine. So this must be the L4 and L5. So it is a conventional method. You just palpate the thing and keeping the your 2 needle here and LOR syringe attached. That once you loss of syringe resistance, you are injecting the drug. So after that, we just injected the contrast. So where the contrast is reaching here up to this area. This is the anterior. This is the posterior. This is the spine process you can say. So this is the posterior. So now the epidural space is here. This is the posterior epidural compartment. This is the anterior epidural compartment. Now we have given the interlaminar conventional epidural. Where the drug is going? The drug is going like that. What happened? This is for giving the L4, L5 or L5, whatever the disc prolapse. Where the disc is here, it is here. Above where it will produce, it is the site of the pathology. But where the drug is going, the mostly here. So it is not targeted. It is just simple conventional epidural steroid. It won't, most of the time it won't work, and the patient will be easily taken for the surgery. What we are going to do that transforaminal epidural steroid injection. What do you mean by that? It is a different kind of approach over the needle. See, I kept the needle, this one. This is the needle I kept. You know, you can understand the drug. This is almost 6 to 8 ml we have given. Still, it is not reaching to the point of the needed, but it is only the 0.5 ml to 1 ml, not more than 1.5 ml at all time. So where it is exactly reaching the site of lesion. So that is called targeted epidural. Transforaminal epidural steroid is the targeted. It is to be given. It is mainly the purpose of giving as closer to the target. That's why the results are also much anticipated than the conventional interlamellar epidural. So whenever the surgeons tell us to go epidural steroid, don't go for this one, because it 95% it won't work unless you specifically close to that. The only indicated interlamellar approach is the cervical regions because of the different problems. So other area, lumbar and thoracic, we don't go for this unless you should read the MRI, you should need the MRI, then where you have to give all the things, you have to do your clinical analysis before putting the needle into the particular places. That's a epidural is not the simple one, it is targeted epidural. So ozone therapy is for the conventional, for the completion sake, this is the very simple one. You can connect the oxygen and the ozone will be, the cylinder is connected to this one, and you can get the ozone from here. It is used for was used for trigeminal trigger point injections, one of the very common office-based procedure. Whenever the patient having jumping myofascial nodules are there, we just palpate, will give the dry needling or putting some local or giving the ozone. Plantar fasciitis pain, myofascial pain, soft tissue injury, spinal pain, but now we stopped that. Even osteoarthritis also we used that previously that. So regenerative therapy is the recent one. It's mainly used for regenerative disorders and the traumatic injuries, especially the soft tissue injuries, and myofascial pain also useful. What are the drugs what we get? Simply the PRP, platelet-rich plasma. This is a pro-inflammatory process which makes them regenerative of the diseased or destroyed tissues. It is the pro-inflammatory drugs. What are the things you have to keep in mind is that there should not be any anti-inflammatory drugs to be given along with this therapy. You have to get a fair amount of the gap between the anti-inflammatory drugs and this one. So the most important thing is the platelet-rich plasma. The advantage is you can inject anything into the, suppose you are giving steroid and everything, if the plantar fasciitis is there, you should not give into the plantar tendon or something. But PRP, you can inject it into the lesion, into the tendon, into the muscle or something like that, because it promotes the inflammation and promotes the healing that. Okay, it's not anti-inflammatory process, it is the, and again is the stem cell therapy also coming up right now. So the results are a little bit promising, but the lot of way we have to go for that. So the newer development is the in drugs and techniques and things also coming right now. So what are the near to the butyl aminobenzate, the drug which is acting after 14 weeks of duration. Suppose if you put a block, if you think up to almost 3 months the patient has to go with pain relief, it is a wonderful, no? So we may expect in future, in maybe 10 years, 5 years, I don't know that, but it definitely going to come with us. Put one block, it will persist for almost 14 weeks. Because the charged local anesthetics, which also prolonged, again the tokinide and butyl tetracanes are on the process of that. New age delivery mechanism, liposomal drugs, which is microspheres, and these are very much useful for that local anesthetics as well as the opioids, which have the extraordinary prolonged duration of the actions. So the percutaneous delivery systems are transpulmonary, intranasal, transdermal, of course it is there, and these are all the novel areas we have. Just a patient is having one puff of morphine or something like that, it is on the way to come. And the aerosolized liposomal depositors and all the things will have the longer duration, the extended release of the epidural morphine, just like one area about give that small amount of the drugs, it will be persistent for a weeks, months, who knows that, maybe years. The patient may have the completely pain-free. All the things are in pipeline. In one day it will come. Again, the most important, again, the promising is the genotype-based pain therapy, which is also that altering some kind of the things, patient will improve the pain relief, especially the complete inability to sense the pain by altering some mutations. So just imagine, no need to worry about where the patient is having the pain. Just alter his genome, he will have the extremely inability to sense the pain may be there. And cytochrome 450, a lot of pro-drug activations. Previously, you are giving the narcotics, patient is not responding. If you change this gene codon, he will be responding to the, now you give the drug, he will be responding. And the patient is having huge, a lot of side effects for the drugs, but we cannot give the opioid for the drugs. Suppose you alter this gene, the side effects will be, especially the dangerous side effects of the respiratory depression will not be there if you're changing decoding these enzymes. So all the things are very fascinating, and it may come in one day and make our life is very easy. So with these things, I conclude my speech, and I want to conclude one more thing is the cryoablation, also one of the coming up in the chemical ablations. You can ablative procedures, chemical ablation, radiofrequency ablation, and cryoablation also coming up nowadays. Because of the probe is little bit very bigger now. Now we are getting the final price. The cost is very high, that maybe the initial ages. So with this thing, I'll conclude my speech. The multimodality approach is necessary for the chronic pain because of its complexity. Interventional pain management works in most situations when all other options are failed. And the combination of the analgesics is very useful for treating very much useful in treating the moderate to severe chronic pain. Adjuvant therapy is needed in most cases, and physiotherapy rehabilitation is essential thing you have to look for that. Can we prevent the chronic pain? The most important thing is yes. If we can, by treating the acute pain aggressively, you can prevent the 75% of the people will not become chronic pain patient. So smiling face we always wanted to see in our things, because it's really a privilege to treat the pain, because the pain relief is considered the basic human rights nowadays. With the things, I'll conclude my thing, and thanks a lot for all the people, especially the Pudukkottai branch, for giving a wonderful opportunity on the platform for sharing our views on the chronic pain management. Thanks a lot, sir. Thank you very much.
Thank you, sir. Thank you, sir. So thank you for giving a detailed explanation about how we routinely deal our patients. Because let me start with the most important part of this topic. We are going for the discussion. I think all the three speakers can join in the forum, so that if there is anyone can answer off. Sir, Dr. Niveta, you had told gate
Yes.
theory, talked about a lot of gate theory. So do you feel is there any shortcoming in the gate theory, and for that some other new theory has been introduced?
Sir, when the gate theory is not effective all the time, when the intensity of the pain signals from A delta and C fibers are more than the other non-noxious stimuli, the gate may fail to work. That is one of the shortcomings that is present in the theories.
What about phantom limping?
Phantom limp pain is due to the plasticity of the.
So
No.
that was the one thing I think which is not explained by gate theory.
Yes.
So because we don't have any fibers there, but still the patient has got pain. I think that's why the Milzak came up with neuromatrix theory.
Yes, sir.
So actually it was a landmark theory, but after this Milzak itself, he came up with neuromatrix theory. Nowadays we are far ahead of gate theory. Now we are in matrix theory. Okay, and GK sir. So
Yes.
if a patient comes to you with, for example, abdominal pain, okay. So how do you routinely, how you clinically examine? What are the investigations you do? And do you feel okay? The word chronic pain is still in our clinical practice.
Yes. Even though it is not very clear questions, I will come to that. Depending upon the age, first of all, we have to go for the detailed history that. So history of the pain, duration, site, any radiating or any aggravating factor, relieving factor, what could be the possible pain score, and is there any history of a trauma, previous surgical intervention. Again, you have to look for that whether the pain is arising from the abdominal wall, all the visceral pain, all the things we have to do that. And the duration of the pain also we have to look at, but character of the pain. Again, I said anything not the burning, crampy associated with the psychological things are definitely. The most important thing is anything going above the three months or 6 weeks will have it as a chronic pain. The accepted definition is the 3 months. So we'll have that definition. So apart from that, not only looking for the abdomen, we have to look for the as a pain holder. Because of that, one more thing is if the patient is having that middle-aged person, especially the female lady, we have to look at, keeping in mind is the fibromyalgia syndrome, and myofascial syndrome also very common, that it will not focus, it will not fall into any anatomical lesioning or any anatomical focusing or something like that. It will different clinical scenario. So we have to look for the patient as a whole, and the clinical examination and the history is very much important. That so then if needed, we can go for some investigations, mainly for radiological guided investigation, especially if the abdominal pain is there. We have to look for any ultrasound, basic ultrasound or CT abdomen, like that. It is the way of my approach to the particular patient.
Okay, so there was a query in the chat box. Is there any investigation to say the patient is suffering from chronic pain?
That's what I am saying, that most of the investigations will be negative unless the patient having any anatomical lesions. Suppose the chronic pain arising from, the cancer pain, we can see that cancer mass will be there. So that's why that we have to believe the patient. The patient is need not to be looking for the all the time anatomical lesion to believe these patients. The patient statement itself is the enough for diagnosing the chronic pain. If it is more than that of the 3 months duration or more than that of the disease process, suppose the patient have the injury over the finger, it should be healed over by maximum of 3 months or 4 months. The patient is coming with the pain over that area after 6 months, that we have to accept the patient is suffering with the chronic pain. The most important thing is the believe the patient. The patient is a personal perception. It is a personal experience. You cannot prove by investigation abnormality alone that.
Excuse me, sir. Chairperson, sir, that question, part of the question from me, the question is, Dr. Kumar has mentioned about that inferior hypogastric block for the patient suffering from lower abdominal pain. So I will ask a straight question just because of that example. See, most of the time, after a laparotomy or laparoscopy, lot of adhesions will be there. That adhesions will produce a chronic pain, which cannot be diagnosed by any mean. So in that case, whether we have to release the adhesions or we have to go for this inferior hypogastric block, that is the question exactly I wanted to ask.
So thank you, sir. There's a post-operative adhesion, post-abdominal pelvic pain is the most important thing, and we want to do that any adhesion by the, nowadays we are doing the diagnostic laparoscopy, and laparoscopic release is done. Even after that, patient's coming with abdominal pain. So most important thing is that we want to rule out any anatomical strangulation, especially the bowel strangulation, to be ruled out for red flag syndromes. Red flag means nothing but it has to be dealt in other way. So that is called red flag. Suppose the patient is having a headache, we have to rule out it is any intracranial bleed or headache or intracranial tension headache. These are the each and every condition we have the red flags. So pain abdomen, we have to rule out any intra strangulation, any intestinal obstruction because of the repetitive surgery. So in this case, even after the laparoscopic adhesive releases, patient is having to come, I will do that. Inferior hypogastric plexus not is going to be useful. Superior hypogastric plexus block will be very useful. You can very well go by the diagnostic by fluoroscopic guided, or simply putting the local anesthetics over that area. If the patient is having 50% pain relief, that is accepted. That is the accepted modality to move further. It can be done ultrasound guided as well as the fluoroscopic guided.
Okay, thank you, sir.
In this case, it will be considered as the diagnostic interventions.
So we had
Sir, one question to Dr. Kumar.
Yes, ma'am.
Kumar, I am Dr. Vijayarani from Salem.
Yes, ma'am. Yes, ma'am. Please.
Okay. No need to say as madam. Just call me as Vijay. But somebody other person doesn't know that we are trans. Sir, he is my classmate. Sir, he is my friend. He's a good speaker. I know him very well. Kumar, ஒரே ஒரு question. இப்போ வந்து as a GP, as a diabetologist வந்து நீங்க சொன்னீங்க இந்த ஆன்டி எபிலெப்டிக் ட்ரக்ஸ் அடுத்து ஆன்டிடிப்ரெசன்ஸ் அப்புறம் NSAIDs கொடுக்கலான்னு. நிறைய பேஷண்ட்ஸ் எல்லாருமே கோமார்பிடிட்டிஸோட தான் இருக்காங்க. எல்லாருமே ஆசிட் பெப்டிக் டிசீஸோட தான் இருக்காங்க. ஸோ விச் ட்ரக் யூ ப்ரிஃபர் ஃபார் எனி நியூரோபதி ஆர் ஜெனரலைஸ்டு பெயின்? எல்லா கம்ப்ளைண்ட்டுமே வித்தியாசமா இருக்கு. இப்போ இன்னைக்கு ஒரு பேஷண்ட் பீட்ரோஸ்டைனஸ் பெயின் அப்படியே பேக்ல போகுது, பேன்கிரைட்டிஸ் வரைக்கும் அவங்க சொல்றது பார்த்தா பேன்கிரைட்டிஸ் மாதிரி இருக்கு. அந்த பெயின் அப்படியே குளூட்டியல் ரீஜன் போகுதுன்றாரு. டயக்னாஸ்டிக் லெவல்ல எதுவுமே நம்மளால பிக்சர் பண்ண முடியல. எம்ஆர்ஐ ஸ்பைன், சிடி அப்டமன், சிடி எம்ஆர்ஐ பிரெயின் எல்லாமே ரூல் அவுட் பண்ணியாச்சு. ஆனா ஹி இஸ் கம்ப்ளைனிங் ஆஃப் பெயின், டெய்லி பெயின். ஸோ வாட் ட்ரக் யூ ப்ரிஃபர் ஃபார் தட் பேஷன்ஸ் to alleviate his depression as well as pain?
Okay, this question is typical for fibromyalgia. I think DK sir, you can talk about how we go with fibromyalgia protocol.
Yes. As you said, this is the one of the very common. Previously, I thought it is only on the young lady. Now we are seeing the most of the male patient also that fibromyalgia syndrome. It is a non-rheumatoid arthritis coming like that. It is classified as a thing like that. So many things are there. Very simple that the patient will have the widespread pain for longer duration. Widespread headache, shoulder pain, neck pain, or abdominal pain, leg pain. Everybody, they will everywhere. You can say that, and it will not be related to any of the anatomical correlation. You cannot diagnose as pain is arising from the shoulder or disc or his gluteal area or the knee joint, other things. Now today he will say that shoulder, next day he will say that. Then three important point we have to put: the widespread pain, both upper half and lower half of the pain should be there for quite longer time, mostly for more than 3 months. Next is the patient will have the inevitable depressions. The third one is the most important, sleep disorder. The three things are that you can boldly diagnose, ruling up the other systemic illness, other causes. The patient is having fibromyalgia syndrome. Again, coming to that, mostly this patient has to be managed with the multimodality approach, the pharmacological agents, mostly the anti-neuropathic drugs, which is pregabalin, and antidepressants, the most preferred one, the duloxetine or venlafaxine, and associated with the most preferred opioid analgesic is not the NSAID, it is the weak opioid as the tramadol. And of course, psychological counseling and rehabilitation method. These pains will not be relieved by taking rest. So don't allow the patient to take more rest. He has to be gradually activated. The most important one is the walking, cycling, and walking in the and this kind of the exercise will definitely improve his thing for longer duration. The vaccine banning will be there. That is the important part of the disease.
Okay, same person, same fever with diabetic patients, heart failure patients. What to do? What is the drug you prefer for that patients?
So again, the anti-neuropathic drugs, you have to select the depending upon his conditions. Pregabalin, it is the Western books, and scales around 300 milligram. Our Indian patients will not tolerate this one. We started with the pregabalin 75 milligram, 1 BD, 1 HS to the 1 BD for after 10 to 15 days. Then again, you can add that the FDA approved drug is for diabetic neuropathies, venlafaxine, as is the duloxetine, and of course, tramadol can be very well easily given for this kind of the patients. Of course, the most important key point is you have to control his blood sugar level. Without controlling the blood sugar level, giving the drugs may not give as the expected results for these patients particularly.
Okay, thank you, doctor.
Thank you, GK.
Thank you.
Okay, Dr. Aishwarya. Okay, we are talking about celiac plexus. Okay, so when do you decide to go ahead with celiac plexus for a patient with CA stomach or CA pancreas?
When the VAS scores are very high and they are not relieved by the usual opioid analgesics, when the requirement is increasing and it's associated with reduced tolerance to the opioids, like more of constipation, and still the patient has severe pain, breakthrough pains, and the analgesia is not adequately met with opioids, we can go in for these interventional blocks.
Okay, can you tell me, okay, you talked about analgesics. Can you guide us, okay, how much you go ahead, okay, with the morphine? Do you set any limitation for the morphine, or do you have any protocol for it? Because you can also add it.
Yes, this is the thing, need not to be reserved, these kind of the interventions need not to be reserved only for end of the stage or these things. Sometimes the most of the patients may not be fit for doing the cases because the severe mass obstructing the celiac plexus and obstructing the vascularity, aorta and nodes. If you cannot approach the celiac plexus by any methods, and if you're waiting for that days together, month together. So it is the patient diagnosed with the pain and palliative care start on when the patient diagnosed malignancy. Need not to be it has to be the end of the chapter of the things or the last. Nowadays, it is the pain relief for the cancer patient start with the point of the diagnosis. Possible things can be done, especially the celiac plexus when the patient is hale and healthy. We used to give the drugs. I personally prefer the patient has to be fit enough to do this kind of the procedures. So the oral morphine, again coming to this, a good choice, but the problem is it has its own limitations. There is no ceiling limitations for the oral morphine. I never hesitate to increase the oral morphine unless it is hindered by the unexpected. I mean, the not tolerate the drugs due to the complications, severe constipation, severe nausea, vomiting will be there. That kind of the patients, the oral morphine should be stopped, and we have to look for the thing. That is the thing. Early interventions especially will help a lot, especially nowadays we are giving the trigeminal neurology also, that we are advising to go for early intervention because the duration of the pain relief for early done will be the longer than that is done at the end stage or after established very much. Especially the cancer patients may not be good enough to do any procedures.
Okay, to summary up, I think especially for celiac plexus, for upper GI malignancies, so the take-home message is do intervention as early as possible. So it really gives good results. Then, for example, if you're going for superior hypogastric, the results may not be favorable. But celiac plexus is the one area where the results is always very favorable for the patients. So I think this is the area where we always insist, do intervention first, even though you are started on morphine. So it really gives good results for the patients. Any other queries? I think, sir, there was some query regarding contrast.
Sir, the chairperson, sir, I asked about that celiac plexus block, whether trans-aortic approach, that's what worries me much. By piercing the aorta and coming out, whether it is justifiable, how they justify it, I want to know.
Okay, sir.
Because that is a strong message she has given.
Yes. Trans-aortic approach is getting popular.
That madam has to say, you give time for her to speak. Let her also speak. What is
yes, Aishwarya, please.
Yes, sir. Through trans-aortic approach, though we go through the aorta, the reported complications are less, sir. Very few cases of retroperitoneal hematoma have been reported. So the most of the time, the vascular injury is self-limited. So,
Madam, 1 second, madam. Whatever it is, whether reported or not, see how you are allowed to pierce the aorta and you say retroperitoneal hematoma is very less. I request the chairperson to intervene. I don't know. I don't have any personal experience in that.
Okay,
I never venture with puncturing the aorta. No, even for axillary artery, we are worried. That is the reason we will not point out brachial plexus. How you can say, what you will do if suppose there is a hemorrhage, what you will do? I have a lot of reservations on that. That is the reason I repeatedly stress that.
Okay, sir. So let me explain, sir. So the location of the celiac plexus as anatomical is on the anterior side of aorta. So whatever we are doing in the classic method, we are just putting our needle by the side of your vertebral body and we are permitting drug to diffuse anteriorly to the aorta. Okay, so your question about is how can you puncture aorta? So aorta is a thick muscular artery. Okay, so whatever we are using is a 22 gauge spinal needle. So it's a small needle. So thing is, we are using a single needle. We directly go exactly to the celiac plexus. So advantage of putting a transaortic is we can use the minimal quantity of neurolytic. We can use only 6 to 10 ml of neurolytic agent. For example, I am doing it in the classic method. So I had to use at least 15 to 20 ml. so that the drug goes anteriorly to the aorta and entraps the celiac plexus. One. First thing, the drug is less used. Second, the target is perfect. Third thing, regarding hematoma. So it's highly muscular. The bleeding chance is very, 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 very less. Okay, it's a muscular artery. It won't bleed because it's a small break and it never bleeds. So routinely, what we routinely do, if we are worried about hematoma or I am worried about bleeding, I do PCV reading on day 1. I check whether the patient has got bleeding or not. So this is done, transaortic is done for exact location. Second thing, to reduce the least amount. Third, to increase the success rate. The success rate is more when you are doing with transaortic approach. If you are worried, okay, I don't want to puncture aorta. If you are worried, okay, I am worried about aorta, the best method is go ultrasound guided anterior approach.
Simple with so many imaging modalities. See, again, the youngsters should not be carried away with so many imaging modalities. I am still worried. Whatever explanation, I will not dare to touch the aorta with a needle. No.
Okay. So the thing is, so far we are doing for number of patients, the failures that we had never came across with any complication. Second thing, ultrasound guided anterior approach is easy to talk, very difficult to do. Because again, when we are going by anterior approach, the chance of perforating your intestines are more.
Yes.
The chances of infection is more. Second thing, the patient will have huge ascites. Your momentum will be caked. So the anatomy is very difficult to locate. So again, there is a chance of some more added complications with the anterior approach, but still, as you told, sir, if you are worried about aorta, go for anterior approach using ultrasound guide. Second thing, as a practicing physicians, we say transaortic is very safe, but provided see the patient's CT or MRI before you intervene. Take the MRI film or CT film, see how the aorta was at the level of T12 to L1. If there is any arteriomatous plague, don't go for any transaortic approach. If there is any aneurysm, don't do. So these are the two things we always see before going for transaortic approach. And
I will add one thing,
contrast agent. GK sir, you want to say something?
That's enough discussion about the celiac plexus. I went through some of the questions. The one more interesting question is the contrast. Contrast we are talking, it is iohexol. It is otherwise called Omnipac in commercial name. Iohexol, it is iodine content water soluble contrast. Why we are selecting this iohexol is the preferred one. It can be given intramuscular, intrathecal, intraneural, intravascular, anything, nothing will happen that. The only thing, anaphylactic reactions to the iodine content may be there, but it's very, 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 very rarely reported. But you have to keep in mind, any drug can produce any kind of the allergic and anaphylactic report, but it is one of the very safe drug, and it has available in various forms, 140, 180, 240, 300. It is all depends upon the iodine concentrations. The most important thing you have to look for that is the renal parameter. Any contrast has to be excreted through the renal only. If the renal parameter is very high, we have to do that. Don't avoid this contrast or use very, very, very diluted when it can be compatible with distilled water also. That's also it can be diluted. So you can all the things. Iohexol is the contrast what we are using that. The dose is not. We are usually you can 3 to 5 ml.
Dr. Kumar, sorry for the intervention. See, there are a lot of questions in the chat box.
Yes, sir.
So if it is answered to the point, I think you can address all the queries, or else it will consume a lot of time here.
Okay, sir. Okay,
reached
sir.
8:15. Just a minute answer, though I request the chairperson to conduct it within a minute.
Complications in celiac plexus, sir. Yeah, we had seen some complications. To be honest, I stopped doing celiac plexus nowadays. I do splanchnic nowadays because I have RF generator. I do RF splanchnic only. Nowadays, I stopped doing celiac.
Yes, we can go through some small explanation because some people might not know that what is splanchnic plexus, why we are doing the radio frequency ablation. Because the celiac plexus is the wider one, it is the wider network. We cannot do the radio frequency listening in that wider plexus. That's why we are going little bit above the feeding fibers of the celiac plexus, which is called splanchnic nerves, which is situated little bit higher. The celiac plexus are done around the aorta at the level of the L1 level. When you are going little bit above, the greater splanchnic, like splanchnic cells are nicely seen, and we are putting the radio frequency listening there. It is possible to do the feeder nerves of the celiac plexus. That is the one way of doing that radio frequency listening of the splanchnics, because it is not possible to do the radio frequency listening in the wider plexus. That's why we are doing splanchnic. Now, this is one of the safer do that. But when you are going above L1, there is a small bit of risk of pneumothorax is also there.
So the next question is, the distension of hepatic capsule due to metastasis can be relieved with celiac plexus or not? So the answer is yes, it can, but provided you have to go for diagnostic block. If the diagnostic block is giving good results, then you can go for neurolysis. But obviously you can add steroids. Steroids really help in those patients. GK sir, in private practice, can it possible to buy alcohol under our registration number, if I'm right?
So
Sir,
register.
The absolute alcohol.
Sir, correction please. In private practice, alcohol for neurolysis.
Neurolysis, yes.
So, yes, sir. This is very much needed, sir. Anybody can buy. So that is called alcohol.
He's asking, can we purchase alcohol? Means I could
Absolute alcohol.
Never mention as a alcohol and neurolytic. It is called ethanol. Ethanol is the drug what we are using. It is a 90% to 99% we are using that. It is available in your in common setup. We are buying through that our pathology department, where they are buying for the some processing of the chemicals. It is available for them to use, and we are procuring from them. And we can buy off-label products which is not meant for medical gradient. Now, previously we are buying that also. That one Merck company was issuing that medical grade alcohol, that is called ethanol, for this kind of the neurolytic blockers. But I am finding very difficult to buy that Merck company. That is the only one brand was available for medical grade. Now we are also using that industrial grade alcohol only, but we don't find any kind of the difficulties.
Okay, sir. The next question: we are doing multiple blocks. Are we medically legally safe?
Yes. The most important thing, all these blocks are part and parts of our career. You are giving epidurals. Only thing that is you are eligible to do that transforaminal. When we are, only problem is you have to learn by doing it little bit safer by guided procedures. Blindly we are doing blindly we are doing that brachial plexus. Now we have to do that with ultrasound guided. This is you are legally viable. You are legally protected fund when you are not deviating your domain. The only problem is intradiscal. That's why I avoided the interventional procedure, the endoscopic discectomy, all the things. That is the one thing which is little bit of controversy is there, whether we are allowed to do that or not. All these blocks are part of your career, and the SAR is well known that all the blocks is important part of your training. You have enough legal training is there, so there won't be any legal problem if you are doing restricted your practice within this limit.
Okay, sir. Okay, sir. So actually, as an anesthesiologist, we have curriculum on pain management. So if you have a curriculum, we are safe. Sir, can you explain few lines about what is RF? We are talking a lot about RF. What is it actually? So in a crispy thing.
So again, the ablation, ablating the nerves, that means the blocking of nerve conductions in particular area. For an example, the trigeminal ganglion, you just imagine it is situated in the intracranially, which is producing some kind of the appetitive stimuli. That's why the patient is having the pain over the mandibular, maxillary, as well as the ophthalmic divisions. What we are going to do that we are just blocking that. That means ablating this particular area of the pain producing signals. So how we can do that? We can do it by chemical ablations, then the radio frequency ablation. That is RF means radio frequency ablation. We are the chemical ablation, again alcohol is there, ethanol is there, phenol is there, glycerol is there for exclusively for the trigeminal. Radio frequency also producing this kind of the what is this core over how to go further, because the procedure itself has the inherent quality of testing by stimulations. That what do you mean by stimulation? Your nerve stimulation. You are doing the nerve block, supraclavicular block. So doing that, but you are stimulating the drug button, the needle, and you are confirming the twitch response. That is, you are confirming that your needle is close to that, and you confirm the motor response. That is where you are giving the drug. The same kind of the thing is available in the radiofrequency machine. We are doing the extra sensory stimuli because the patient is suffering with the pain. So I'm putting the sensory stimuli that is called 50 hertz. Then the patient is having concordant, the painful stimuli or lesser quality of the pain over that particular area. So I confirm it. That is the way it is precise, safe, and it will avoid the seepage of the unnecessary. If suppose you are giving 3 ml of drug, it may go anywhere else, not only going to restrict it, but the lesion producing very precise. It is less than level only, millimeter level only. Those the lesioning will be very accurate where the area it is going to be there. We have the control over the needle and confirmation over the needle placement, and that's why the complications are little bit less and comparatively to the conventional chemical ablation. That's why the radio frequency listening scores over that. In radio frequency, again, I thought conventional radio frequency producing simple lesions, whereas the pulsed radio frequency that produce some kind of their neuromodulation. Not only it won't destroy any nerve fibers, it will produce the neuromodulation changes, and it produces the pain relief is there. And the cooled RF is there, another technique which have the larger lesions, so longer duration of the pain relief. That each and has his own limitations and indications.
Thank you, sir. Thank you, sir. So now we are coming for the end. So it's really a nice discussion, sir, because you have given your all your experience. Those who are attended this session, I think now beyond anesthesia we have gone more. So pain medicine is the area where we had expanded like anything. Most of us may not be aware about pain medicine because when we did an MD, when we are in the MD, we don't have that much experience on pain medicine. Nowadays, the youngsters nowadays are getting more exposed to the pain medicine. So for a pain medicine, for a doctor, for anesthesiologist to practice in pain medicines, it's really need another curriculum. It's not a part of anesthesiology. Pain medicine is not a part of anesthesiology. It's beyond it. So we have to read clinical methods, how to examine these patients, what will be the probable diagnosis. So you should know when to touch the patients. You should know how to conservatively manage the patient. Then you should know how to intervene the patients. Intervention is just a technical skill. But only thing, nowadays we are not doing any procedures under blind technique. We are doing only under image guidance because we have to be very safe with the patients. So I request all of you, those who have joined in this session, to start read about pain medicine.
Sir, one more question to Dr. Kumar sir. He told about the gene-based therapy for pain. Is it necessary to do a gene mapping for chronic pain of patients with cancer or the neurologic pain, sir? Is it necessary or?
Madam, it is for postgraduate to add completion sake. It is the future scope we are looking for that. In future, who may know that in next generation will do only the gene modulation for pain medicine. We don't know that. These are all the future development. It is going around. It is a promising also that.
Thank you, ma'am. We are running short of time. So thank you, GK sir. Thank you, Aishwarya, and thank you, Dr. Niveta, for joining us. And great thanks to Dr. Elam sir. So you are the one who had been venturing a lot of things. Thank you, sir. Thank you, Elam sir, and ISA Pudukkottai team for giving us the chance to giving us to talk about our another branch, pain medicine. So thank you, sir. So I think I can hand over to Elam sir to summary up and close the session.
Thank you. It was nice, even though for want of time, we have overshot the time this time because of the interesting discussion. Now I hand over the session to the President, Dr. Suresh Kumar.
Thank you, sir. Wonderful session. Kudos to all the speakers and chairperson. A large topic. It cannot be covered in these 2 hours. In spite of that, every speaker had their very fantastic discussions in addition to their presentations with videos and other things. I will thank all of the speakers and chairperson and our ALM sir. Till we meet in next Pudukkottai Budan, I invite our treasurer to propose the vote of thanks. To Dr. David, please.
Yes, sir. Good evening to all. On behalf of ISC Pudukkottai, first of all, I would like to thank our academic chairman, Dr. Elam sir, for such a wonderful topic today. Thank you, sir. And I would like to thank today's chairperson, Dr. Gurumurthy sir, director, and Dr. Guru's Interventional Pain and Palliative Care, Richie, for sharing his wonderful experiences. And special thanks to Dr. G.K. Kumar sir, Professor HOD, Department of Anesthesia, Government of Multimodal Medical College Hospital, Chennai, for his wonderful lecture. Thank you very much, sir. Also thank other speakers, Dr. and Nideta, for excellent academic session. Thank other faculties, postgraduate, and even logics, Epidural for technical support. Thank you. Thank you, sir.
Thank you very much, sir.
Thank you.
Thank you. Thank you all, sir.
Thank you, sir.
Thank you. A1 Logics, you can end the meeting. A1 Logics.
Went for dinner, it seems.
Then we can leave. We can close. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.